So out of 4 different types of Monteggia fracture dislocation, according to Bardo, the most common type is the type 1. Alright, type 1 is the most common type, where the fracture is apexed anteriorly and the dislocation also is happening anteriorly. That is the most common type. The point number, so what we have discussed, the definition we have discussed, you came to know the definition of Monteggia. Second is the classification we have discussed. The third one is, what is the most common nerve which is likely to get injured associated with this fracture? So the answer for that question is posterior interosseous nerve. All of you are aware of the fact that posterior interosseous nerve is the branch of radial nerve, but more importantly, posterior interosseous nerve is a pure motor nerve. Alright, it is a pure motor nerve. That means it has got no sensory component. So when the posterior interosseous nerve is injured, alright, there will be no loss of sensations anywhere in the hand. All of us are aware of one thing, is that the first dorsal web space of hand is exclusively supplied by the radial nerve, and PIN is a branch of the radial nerve. If PIN is injured, there will be no loss of sensation. If radial nerve is injured, there will be a loss of sensation over here. Now, this is reflected in your question, a sample question that we have provided. Now, what is there in the sample question? Again, came to emergency after sustaining the fracture of the proximal ulna with dislocation of elbow. So, you combine proximal ulnar fracture with dislocation of the elbow. That means we are talking about Monteggia fracture dislocation. Now, on examination, his metacarpophalangeal joint extension was lost. It is one clinical feature of PIN injury, but the sensations in the hand were intact. That means it is Monteggia fracture dislocation associated with the most common nerve injury associated with Monteggia, that is posterior interosseous nerve injury. What is the diagnosis? So, answer for this question is, it is Monteggia fracture with posterior interosseous nerve injury. Alright. Next comes the management of this Monteggia fracture dislocation. The treatment. Now, what do you expect should be the management? If I give you 3 to 4 options, like, will you do a closed reduction? Imagine if you have performed a closed reduction, then because the fracture is unstable, it will be reduced again. Alright, there will be a recurrent dislocation and there will be a recurrent displacement also. So, closed reduction and immobilization is never the answer for Monteggia fracture dislocation. Always the management for Monteggia fracture dislocation is achieved by open reduction internal fixation. Alright. So, what you do in open reduction internal fixation is that you open the fracture site, you reduce the ulna. After reducing the ulna, you fix it with any of the appropriate implant. And once you fixed and reduced the proximal fractures in the ulna, the radio-ulnar joint subluxation or dislocation will be reduced spontaneously, automatically. Alright. And then you have to go for slab immobilization or sling immobilization. So, that is the management protocol. Always open reduction internal fixation for the management of Monteggia fracture dislocation. So, hope everything is clear related to this fracture. A quick revision of what we have talked about under this heading. Number 1, we have started with the sample question where everything was provided to you. Everything included means the definition. Second is the name of classification. You also came to know that what is type 1, the keyword is anterior, type 2 keyword is posterior, type 3 keyword is lateral. And you know the reasons why. If the apex is anteriorly angulated, there will be a dislocation anterior also. Then we have talked about the nerve injury associated with this is the PIN, which is very, very frequently injured. You know, in the management also, if it is not injured during the fracture, it might get injured during the management or the treatment, during the fixation of the ulna. And finally is the treatment protocol, that is open reduction internal fixation. Alright, about Monteggia fracture dislocation. Next, why this question is particularly important? Because it has to be compared to Galeazzi fracture dislocations. Now, what is Galeazzi fracture dislocation? As the definition is very much indicative that it is the fracture of the distal radius with distal radio-ulnar joint subluxation or dislocation. Now, what was happening in Monteggia was proximal ulna with proximal radio-ulnar joint subluxation. In Galeazzi, distal radius with distal radio-ulnar joint dislocation or subluxation. This is what is happening in case of Galeazzi. Because of this confusion, the examiner is asking the question related to these. Now, one thing is important related to Galeazzi also. Imagine this is the distal end of the radius, and here there is a distal end of the ulna, and here we are having a wrist joint. So you should also be aware of the anatomy of the wrist. Imagine if there is a fracture in the distal radius with distal radio-ulnar joint subluxation, then all the soft tissues which are present inside the distal radio-ulnar joint could also be injured. So important soft tissue that you should be aware of in the wrist joint is TFCC, that is triangular fibrocartilaginous complex. It is a triangular fibrocartilaginous complex which is made up of the distal radio-ulnar joint anastomosis. It is made up of the radiocarpal joints, ulnocarpal joints. All right. So if there is an injury to the distal radius with subluxation, then the soft tissues in the wrist joint could also be injured. And this could be projected in your question. Like, if imagine I give you one option, like which of the following is a Galeazzi fracture dislocation? And under the option, it is not mentioned that there is a fracture of the distal radius with distal radio-ulnar joint dislocation. Rather, it is mentioned that there is a fracture of distal radius with TFCC complex injury or TFCC injury. Then also it will be a Galeazzi fracture. So if there is a fracture of the distal radius associated with the distal radio-ulnar joint dislocation with associated soft tissues of the wrist injury, it will be called as Galeazzi fracture dislocation. Again, the management protocol remains the same. That is always open reduction internal fixation, that you have to reduce after opening the fracture site. That means stabilizing it, and then you have to reduce the fragment. So open reduction internal fixation is the management protocol or the treatment for this Galeazzi fracture also. All right. So the treatment is open reduction internal fixation always. Because by closed reduction, there is a possibility of malunion, there is a possibility of non-union, complications, instability at the fracture site, difficulty in the movement, stiffness, all these complications might pursue. So open reduction internal fixation is the management protocol for both Monteggia as well as Galeazzi. Now, if you go back to the sample question again, like which of the following is a diagnosis? What is the diagnosis for this condition? Now, first of all, look at the x-rays. Here, the distal radio-ulnar joint is found to be subluxated. That means distal ulna obviously is not in a position where it should have been. But as you can see that the distal radius is malunited. There is no evident fracture at this point of time. So it is old Galeazzi fracture which was neglected, which could be managed by any other means rather than open reduction internal fixation. So what is the diagnosis? Is it Monteggia fracture dislocation with malunited radius? Obviously not. Is it Barton's fracture with distal malunion? Obviously not. Is it Galeazzi fracture dislocation with malunited radius? That is the correct answer. All right. Is it the Colles fracture? Again, not. All right. So with distal radio-ulnar joint subluxation or dislocation, these are the things that you need to remember about Galeazzi. Hope everything is clear related to this topic, Monteggia and Galeazzi in particular. Galeazzi related questions are very commonly asked. All right. Now, let's have a discussion on the management of fracture both bones in the forearm. Now, just try to understand, both bones of the forearm are radius and ulna, and in the mid shaft region, the fracture occurring in both these two bones is a common phenomena, all right, because it is the result of an indirect injury that both bones are getting fractured. Now, as far as the management of these both bone fracture is concerned, and if you have to manage it by conservative means, not by surgical means, then how the application of cast is going to be different. Only simply you need to remember how the application of the cast are going to be different depending upon the levels these bones are affected or these bones are injured. You see, if the fracture is in the proximal one-third part, then the immobilization achieved by above elbow cast has to be in supination. Why? Because it is the only supinator muscle which is responsible for supinating the proximal fragment. So you have to supinate the distal fragment also so that the radius gets aligned. Both these two bones gets aligned. But if the fracture is there in the mid one-third region, then because of the pronator function also, the action of supination is neutralized. So in that case, you have to put it in the mid pronation. That means in the neutral position. Alright, so that is the only difference. If there is a fracture of the both bones in the forearm in the proximal aspect, you have to supinate it and immobilize it. If there is a fracture in the mid 1/3 region or below, then you have to kept it or keep it in the neutral position, because the pronation or the pronator is neutralizing the supinator effect. Hope you have understood. Because all these things means till this level they have not asked any single question related to this particular topic, but there is also a possibility, always a possibility, that they may go asking about this basics. All right, next. And as far as the treatment regarding surgery is concerned, it is treated by the placement of a small fragment dynamic compression plate, SFDCP. Although no one is going to ask you, this is how the surgical management is achieved in case of adults in particular. Now, what is this? Is it a both bone fracture? If you look at this image, is it a both bone fracture? Obviously not. There is an isolated fracture of the ulna with intact radius. So it is nightstick fracture. Alright, what is nightstick fracture? It is the isolated fracture of the ulna with intact radius. So there is fracture of the ulnar shaft without any fracture of the radius. So fracture of the both bone of the forearm, as I told you, is the impact because of indirect injury. But this impact, fracture, isolated fracture of the ulna, is the result of direct injury. And that is why it has gained its name, nightstick fracture. It is because of the impact of a stick. Imagine someone is about to aim you with the stick, then how to protect yourself? By the placement of the forearm. This is how you are going to protect your face. As a result of it, this stick will have the impact directly onto the ulna, breaking it. So it is the result of direct injury, and that is why it is important. Most of the time, it is seen in practice, practically what happens, that majority of the time it is left as such. Alright. But ideally it should be treated by open reduction internal fixation. Although it is not going to be asked from you in the questions, but ideally it should be managed by open reduction internal fixation, because the alignment as well as compression has to be achieved in order to make this ulna unite. Otherwise it will fail to unite. And the possible complication related to this isolated fracture of the ulna is non-union. Non-union is considered to be the commonest complication associated with isolated fractures of the ulna. The compression has to be achieved by the placement of small fragment dynamic compression plates. Alright, so open reduction internal fixation is always the management for this. Okay, now although it is written as nightstick fracture, it is actually not the nightstick fracture. This is not the nightstick fracture. This is the nightstick fracture that we have already talked about. It is the fracture of the both bone of the forearm, which was managed by the placement of the plates. Now, this is what the green stick fracture is. Alright. Now, what is green stick fracture? You have to write down the definition in order to understand the green stick fracture. It is a unicortical fracture of both bones in forearm. Unicortical fracture of both bones in forearm. That is the definition of green stick fracture. Now, what does it mean, unicortical fracture in both bones of the forearm? Just try to understand. Imagine this is the radius and this is ulna. Alright. And if there is a fracture of one cortex only of both the bones, then it would be called as unicortical fracture of both bones of the forearm. Alright. Now, in order to have the unicortical fracture with the intact other cortex, there has to be an increased laxity of the bone. There has to be decreased strength of the bone. And this increased laxity is a feature of a bone in case of a child. That is why green stick fracture can happen only in case of children. It is a fracture in children. This is the fracture which is observed only in case of children because of increased laxity of the bone. Now, if you look closely in this fracture, that there is a lateral cortex of the radius which is broken, lateral cortex of the ulna which is broken, but the medial cortex is intact. Here, there is an intact medial cortex. And this is how unicortical fracture of both bones of the forearm are called by the name of green stick fracture, which can happen only in case of a child. Alright, because of increased laxity of the bone, because of decreased cortical strength of the bone. Hopefully, everything is clear related to the fractures of the both bones in forearm. Then, the management of the fractures of the both bone in forearm conservatively as well as surgically. Then, nightstick fracture,